of providing genetic counseling in your breast center. I am Rachel Elliott with Chordata Healthcare Innovations. For those of you who have not yet heard the news, Priority Consult recently acquired another company, and together we've created Chordata Healthcare Innovations. We're in the middle of this extensive process of changing our company name and our logos on all of our materials. So you will be seeing some changes on our website and supplemental materials over the next few weeks, like you see on this slide, the new Chordata logo. Before I introduce our presenters today, I did want to take a moment to invite you to our workshop this September 25th and 26th in Indianapolis. This is an educational event for oncology professionals. We have scheduled presenters to speak about a variety of topics, including survivorship, integrative health coaching, Commission on Cancer surveys, as well as additional focus on the topic for today's webinar, genetic counseling. So if you would like to register or review the agenda, you can go to our website, which is still priorityconsult.com. And if you do decide that you'd like to register, if you email education@priorityconsult.com, which you can see there on the slide, you can get a $100 discount off of the registration fees. So I hope you'll consider that today. Okay, so our presenters for the webinar today are Mary Freivogel and Allie Anguiano, genetic counselors responsible for patient risk assessment and prevention at Invision Sally Jobe in Denver. They've agreed to answer questions after the presentation, so feel free to type your questions, any questions you might have, into the question field in the GoToWebinar panel on the right side of your screen. I also have several questions that we received during the registration for this event, and so they're going to address those at that time as well. Okay, thanks again for joining us today, and I am going to hand things off to Allie.
Thank you, Rachel. My name is Allie Anguiano, and Mary Freivogel is also on the line, who will be coming in about halfway through the presentation. We're going to be presenting the practical value of providing genetic counseling in your breast center. We're both certified genetic counselors at Invision Sally Jobe / Radiology Imaging Associates out of Denver, Colorado. The objectives of our presentation today, so the first one will be to describe the process of genetic counseling for two distinct populations of patients. So those who have had breast cancer or are affected currently with breast cancer, and those who are at high risk based on family history. We're going to understand the increasing complexities of cancer genetic testing, discuss possible methods to systematically identify women who can benefit from genetic counseling and a supplemental breast screening, and also review the clinical and financial outcomes of hiring a genetic counselor to oversee a comprehensive breast cancer risk assessment program, such as we have at Invision Sally Jobe. So first of all, just want to go over briefly the components of cancer genetic counseling. So pretest counseling and data collection are very essential to the genetic counseling process, and these are specific to cancer genetic counseling. But relevant personal medical history, including age, race, age of menarche parity, menopause status, ethnicity, and we're especially concerned about Ashkenazi Jewish background on maternal and paternal sides of the family, history of breast biopsies and what were the pathology of those biopsies, exposure to mantle cell radiation, which is typically a treatment for lymphoma, prior genetic testing, so has this individual actually had genetic testing in the past and what was it for, and previous cancer diagnoses such as site, pathology, and age. And then additional, the data collection for family members is extremely important. So the pedigrees are typically 3 to 4 generations and include maternal and paternal family of history, including who had cancer in the family, the type of cancer, the age of onset, the ancestry of the family, the backgrounds, maternal and paternal sides, again, especially Ashkenazi Jewish background, and then if any genetic testing has been completed in relatives and what were those results. As you can see here, this is an example of software that can build a pedigree for you. This is a 4-generation pedigree, maternal and paternal sides, and you can see ages of diagnosis and who in the family has had cancer. So the first question that we need to ask ourselves when we're looking at a pedigree is that, is there a suspicion of a hereditary cancer syndrome? If there is a suspicion for hereditary cancer syndrome, then what is the differential diagnosis? And typically this can be long or it can be short. And then informed consent, so making sure to go through all of those objectives, which we'll go over in just a few minutes. And then if we're going to do genetic testing, what is the genetic testing for? The pre-test counseling and the informed consent process is extremely important. So the purpose of the testing, so why are we actually doing testing for this individual? Who in the family is actually the ideal person to test first? So it might not always be the person in your office, so that warrants a discussion with that individual. What are the possible test results, including inconclusive results? And how will different results impact that individual's medical management? The likelihood of a positive result, the technical aspects and accuracy of testing, economic and insurance considerations. So many people have lots of questions about how much will testing actually cost them. And also about genetic discrimination laws, which people have a lot of questions about, which we just wanted to point out that GINA is a law that protects against health insurance as well as employers from using genetic discrimination to discriminate against an individual, which is separate from the Affordable Care Act. State by state, there are differing laws based on long-term care, long-term disability insurance. That is not covered by GINA, but different states have more protective laws in addition to GINA. So it's very important to understand what the laws are in your individual states. Alternatives to genetic testing as well. So if the individual chooses not to do genetic testing, then what are their options? So cancer genetic testing in the recent time has become much more complex. So for one reason, the Supreme Court ruled that genes cannot be patented. So BRCA1 and 2 testing is now offered by multiple labs starting last year. So it used to be that we would really know exactly where a relative was tested if testing was completed previously, but this has become a lot more complicated. Additionally, we're not just testing for BRCA1 and 2 genes anymore. Typically, many patients are opting to do multi-gene panel testing, where we're testing other high-penetrance genes at the same time, such as P10 for Cowden syndrome or TP53 for Li-Fraumeni syndrome, and also potentially testing moderate penetrance genes, including CHEK2 RAD51C. You can see that we put potentially high penetrance genes because, for example, a recent publication on PALB2 showed that this might be more of a high-risk player than we originally thought. That came out in the New England Journal of Medicine recently, so I'd urge you to read that publication. These multi-gene testing panels are great because they allow us to test for many genes simultaneously and for one price, but they do come with certain complications as well as including increased risks for uncertain variants. So one lab estimates that about 25 gene panel has a 40% risk of uncertain variants. So that's very much higher than it was before. As well as what are we going to do with these genes that we call moderate penetrance when there's no medical management guidelines for them. So this is an example of the power of these multi-gene panels. This is data from the University of Washington BRCA panel. So you can see here, this is a very high-risk family population. So 800 families is greater than 3 cases of breast or ovarian cancer, where the proband was actually negative by BRCA1 and 2 commercial testing. So you can see here that 20% of these 800 cases were actually resolved with this kind of testing. So 8% had undetected or unreported BRCA1 or 2 mutations. This included that an individual other than the proband had a mutation, or includes the fact that sometimes BART testing or large rearrangement testing may not have been done previously, or other undetected mutations that weren't reported on commercial testing. 8% included well-characterized gene mutations, so CHEK2, PALB2, TP53, and 2% occurred in these less characterized genes, such as BRIP1, ATM. So the post-test counseling, which post-test counseling is in parentheses because not every patient who's a candidate to do genetic testing will actually do genetic testing. So some people actually decline to do genetic testing, as well as not every person who comes to your office will even need genetic testing. So it's not always indicated in the patient. So in these individuals, where do we go next? So if there's a high risk for breast cancer in the family, which is what we're focusing on today, then breast cancer risk assessment, including genetic testing results of the individual or family members, family history models, and then also taking into account their breast density. Discussion of personalized medical management options and referrals to specialists. So now that we have this information, or we're not going to do genetic testing, then what do we do next? Available resources for patients. So if they are BRCA positive or have Cowden syndrome or something like that, who do we need to send these people to for support? Information for relatives as well. So relatives will need this information, especially if the relative is tested positive, but also if the relative is tested negative. And how are we going to get this information disseminated to those individuals? And also psychosocial assessment. So some people will take news differently than other people, and there are limitations to what we can do. So knowing when to refer those individuals out. So the first population I want to talk briefly about is the genetic counseling for the patient with breast cancer. So criteria for further genetic evaluation include an affected individual with breast cancer under 50 or any age of Ashkenazi Jewish descent, triple negative breast cancer, 2 breast primaries, breast cancer at any age with these findings here, ovarian cancer at any age, male breast cancer, or the combination of breast cancer with any of the following things that you can see listed here. And this comes from the NCCN guidelines. So in newly diagnosed patients, it is helpful to have a system at your center to figure out who's going to review each of these patients' information at the time of their diagnosis. So typically at our center, a navigator or genetic counselor reviews this patient's history, personal and family history. Those who meet NCCN guidelines are offered genetic counseling/testing immediately, and that can account for up to 20% of newly diagnosed patients. The reason that we're trying to get these patients to consider this early on is because it can really change their surgical choice and treatment plan. So some of those patients, if they do have a gene mutation or find out they have a high risk for second breast cancer, may choose to do mastectomy or something like that when originally they might have planned to do lumpectomy otherwise. It can also change the recommendations to other cancer risks, such as ovarian cancer. And again, can have very different implications for relatives if they are gene positive versus if they do not carry a gene mutation. A recent publication really helps to support this rapid genetic counseling model. This is out of Italy, but compares 2 models and approaches. So the traditional testing model, where somebody came to your office after actually having surgery previously and then had genetic counseling and testing. So only about 4.7% of those individuals actually chose to do a risk-reducing mastectomy. Compared to the rapid genetic testing model, which was genetic testing or counseling within 3 to 4 weeks prior to surgery, where 42% of mutation carriers actually chose bilateral mastectomy. This is a huge increase in the number of people who are changing their surgical decision based on this information. So very important information for them to have to make well-guided decisions. So we also see in our breast center patients who have a personal history of breast cancer. So they don't have a cancer history currently, but they have had cancer in the past. So for those patients at the time of their follow-up imaging, typically, we review their personal and family history, and again, offer genetic counseling and testing to those who meet NCCN guidelines. Again, outcomes are similar, so change in current screening recommendations or risk reductions, so they might choose to have mastectomy at that time if they were found to be positive or something similar. Recommendations for other cancer risks, so they potentially could have risk for ovarian cancers or other cancers. And then again, implications for relatives are very different for those who have a gene mutation. So this is very different, the patients who have actually had a cancer diagnosis, than the patients who are at high risk based on their family history and are unaffected. So we break out risk of breast cancer into different categories. You can see the 4 categories here. So average risk is considered a lifetime risk of less than 15%, and in a few minutes we'll go over some of the models that we use to calculate these risks. Intermediate risk is considered to be 15 to 20%. High risk is considered to be a risk of 20 to 25% or greater. And then a 4th category, which is all on its own, because hereditary risk, so a person has a gene mutation, is a very different risk for breast cancer and much, much higher than we'd ever predict by models alone. And this hereditary form of high risk also elevates risks for other cancers associated with the particular syndrome. So in those that have intermediate risk at our center, we urge those individuals to consider screening breast ultrasound if they have dense breast tissue. So trying to take into account dense breast tissue at some level. Those that are at high risk who have a hereditary high risk for breast cancer are to consider doing breast MRI screening every year. And breast MRI screening as well as screening breast ultrasound are both in addition to, not instead of, mammograms. There are several tools to assess breast cancer risk, and you can see some of them listed here. So first and foremost, before we ever get to any models or anything like that, again, the first question to ask is if this person actually has a potential cancer genetic syndrome. So the guidelines for cancer genetic testing, again, can be found on the NCCN guidelines. If this individual does have a suspicion for a cancer genetic syndrome and they are found to be positive, then we would never go on to use models secondary. So secondary to using these models is if this person chooses not to have genetic testing, we don't know their genetic testing results. But genetic testing results, if available, should be used first. Moving on to the breast cancer risk assessment models, so there are several models listed here. You can see GALE is one that's very easy to use and many people are familiar with. It's not actually officially recognized by the American Cancer Society to identify candidates for breast MRI screening. That's because Gale has many limitations, such as only taking into account first-degree relatives, so it's not very robust for family history. Klaus, you can see, is another model, which before used to be very time-intensive and to compute and have to have special formula, but now there's actually an app for the iPhone and iPad called BRISK, where it's very easy to type in a person's information to get the Klaus risks. Tyrer-Cuzick is another one that people are familiar with. There are two versions of Tyrer-Cuzick available currently. So one is version 6 and one is version 7. Version 6 is the one that has been recognized as the ACS as a model that is okay to use for MRI screening. The version 7 model does put people's risks at higher, and so some people have criticized that model as it's not quite ready to be used yet, but the advantage of using that 7 model is it does take into account male breast cancer risks. BRCA Pro is another example. That's actually a software that not only builds a pedigree, but also helps to calculate lifetime risk for breast cancer, risk to have a mutation. And that takes more time to enter, as well as needs to put in unaffected relatives. Boadicea is a third model. Boadicea is something that we don't use very often because it's very labor-intensive to input that information, but it does take into account both maternal and paternal sides of the family. So which risk model to use? So I just listed several of them. So there's three recognized models, BRCA Pro, Klaus, and Tyrer-Cuzick, that take into account family history very differently, and each are derived using different statistical methods and populations. But as you can see here, these models can really detect different people who are over 20% or greater. So Tyrer-Cuzick, if you were to choose one model in the breast center to identify these patients who are candidates to do breast MRI, Tyrer-Cuzick, as you can see here, will identify the most patients. And one of the criticisms of Tyrer-Cuzick is that maybe it over-identifies people who are at high risk. But you can actually see here that it does tend to miss certain individuals. So Klaus as well as BRCA Pro can pick up individuals that Tyrer-Cuzick does miss. But if you were going to choose one model in the breast center, Tyrer-Cuzick will pick up the most patients that are potentially candidates for this type of screening. So despite these differences, these models have been chosen for the same purpose, to identify people who are candidates to do breast MRI screening. And in the genetic counseling visit at our center, we go really more into detail with these methods. So limitations of risk assessment models. So there are some limitations. So breast density is not currently addressed at all by these accepted models. So it's important to figure out how you're going to take that into account in your individual centers. Personal history of ALH and ADH and LCIS. The ACS doesn't actually recommend for or against MRI in these patients, and certain models can do account for ALH, ADH, for example, Tyrer-Cuzick, but these they question, what are these risk estimates, and they seem high, and are they accurate? So personal history of breast cancer, most models do not address the risk of a second primary cancer, and these risks are likely higher in women who have an early age of diagnosis or they have a strong family history of breast cancer. And the American Cancer Society also doesn't recommend for or against breast MRI in those patients. And again, a hereditary cancer syndrome in the family. So the presence or absence of a gene mutation, again, is the most important feature to identify, because if this individual has a gene mutation, these models are never going to put their risks at the level that someone may have if they have a BRCA mutation or P10 mutation. As well as the absence of a gene mutation in a family with a known familial mutation is very different, and these individuals wouldn't be considered high risk anymore. So it's very important to take these hereditary cancer syndrome families into consideration. So a potential algorithm for breast cancer risk assessment is, again, to ask yourself first, is this patient at risk for hereditary cancer syndrome, yes or no? If it is yes, then the patient should consider genetic testing, so visit with genetic counseling to figure out if that's something they want to move forward with. If there is a mutation found in the family, then again, these models are not useful, and what are their risks based on empiric data that there's many, many papers to find that information for. And the presence and absence of a gene mutation in a known familial mutation family can really determine what this individual's risks are. If they do consider genetic testing and they're uninformative, or maybe that individual chooses not to do genetic testing, then really we go on to the other side, which you can see is that this patient is not a candidate to do genetic testing, or we don't see that there's a hereditary cancer syndrome suspicion in the family. Then we rely on these models to kind of figure out what are their risks, how should this patient be screened, and what do we do next. As you can see here, this is the hereditary cancer syndrome risk factors. So you can see all the way to the left, the BRCA mutation is the single most high factor for increasing risk in an individual, tenfold. And you can see some of the other things that are, for example, taken into account for in the other models, such as age of menarche, menopause, weight, hormone replacement therapy use. None of these factors are ever going to increase an individual the amount that a BRCA mutation does. Breast tissue density, you can see listed here, atypia history on a biopsy. So really, again, the most important question to ask yourself is, does this individual have a high risk for breast cancer because they have a hereditary syndrome? Because none of these factors that are taken into account by, or maybe not taken into account by the models, will ever increase their risk such as that. And now I'm going to turn it over to Mary for an example for a patient that we had in the center.
Wonderful. Thank you so much, Allie. So yeah, I wanted to just basically share with you, this was a patient that was actually one of the first ones that I saw at Invision Sally Jobe back when I joined in 2009. But it's such a good case, and so we like to use it in presentations. And it starts off with a 50-year-old female who actually came to us for a routine screening mammogram. And she was identified to have a focal asymmetry in her left breast on the screening mammogram. And so this area that's circled shows where that focal asymmetry was seen. So of course, we brought her back for a diagnostic mammogram and ultrasound. And here's one of the spot compression views. And after further evaluation, they basically decided that there were no abnormalities. And so the recommendation was for her to come back in a year for another screening mammogram. But we were actually collecting information about family history. And so, you know, we collected the information that we needed to run the Tyrer-Cuzick model. She was at about an 18% lifetime breast cancer risk on that, so she wasn't meeting that 20% threshold for an MRI. But she had a family history of ovarian cancer in her mother at a fairly young age, as well as breast cancer in her sister at a fairly young age. And so based on that combination of breast and ovarian cancer, the radiologist said, you know, hey, I think you should see our genetic counselor. So this woman came in to me. We did run additional breast cancer risk assessment models on her during the visit. And again, she wasn't coming up high risk on any of them. But when we looked at her, you know, family history, we realized that, you know, she was somebody who was a candidate for genetic testing because of that association of breast and ovarian cancer in the family. And the models that we used gave her somewhere between a 4 and 12% risk to test positive for a BRCA gene mutation. Nobody in the family had been tested. Both her mother and her sister who had had the cancer were deceased. So the only option really was to do genetic testing in this patient. Sometimes we do like to, in an ideal world, test somebody who's had cancer first, but a lot of times that's not possible either because the relatives with cancer are deceased or they're not available to be tested or not willing to be tested. So for this patient, we did genetic testing, and she did come back positive for a BRCA1 gene mutation. So we brought her back and talked with her about the recommendations that needed to happen from there on out. We recommended a breast MRI. So that was kind of the first thing that was on our agenda. And she had a mildly suspicious pattern, again in the left breast, but it was actually more in the central part of the left breast. It was a different area than we had looked at based on her screening mammogram. And so this is just an MRI image to show you the area that we were concerned about on the MRI. And again, if you remember before, the circle that I showed you was a little bit higher. Now the circle of the area of concern is in a different area that hadn't been called out initially on that screening mammogram. We did an MR-guided biopsy, and this woman actually had DCIS in that area. So, you know, looking back, this is something where if we hadn't, you know, even if we ran the risk numbers, we wouldn't have recommended an MRI for her. And it really underscores the important need to identify women who should have genetic testing or be offered genetic testing before you make any recommendations based on what those models say. Because if we had gone on what the models said, we would have just told her to come back in a year for another screening mammogram. But based on that combination ovarian and breast cancer. We identified that BRCA mutation. We recommended the MRI due to that mutation, and we ended up finding an early stage cancer that may have been missed if we didn't do that MRI. She did have bilateral mastectomy as a treatment for her DCIS. She had actually previously had her ovaries and uterus removed, so that was not an issue for her. She did have 2 daughters, and at that time they were ages 21 and 23. The 21-year-old did choose to undergo testing, even though she was very young. She really wanted to know these results. She went through genetic counseling, and she did test positive. She did consider preventive mastectomy, but ended up not doing that at such a young age. Her plan is to begin annual MRI at age 25, and then we add annual mammograms at age 30, and then to consider using oral contraceptives to reduce her risk of ovarian cancer. The patient's other daughter was 23 at the time, and she had declined genetic testing. So our recommendations for her were that if she isn't tested by age 25, we assume she's positive, and we start annual MRI in her then, unless she chose to have genetic testing and was proven to not have the mutation. And then in that case, she wouldn't need to be screened until age 40 when she would begin mammograms. And then again, the consideration of using oral contraceptives for ovarian cancer risk reduction. So now I'd like to tell you a little bit about our experience here at Invision Sally Jobe with sort of building this program. And I joined, like I mentioned, in 2009. But first, I kind of want to just give you a little background on who we are as a practice so that you're kind of aware of, the setting and where we are coming from. So we are a certified quality breast center, but we are a private practice and really just an outpatient setting. We do have a fairly high volume. We perform about 75,000 mammograms per year between 11 sites, and we're in the Southwest Denver metro area most often. We do all kinds of breast imaging, from mammograms to ultrasound to breast MRI and all the way to biopsies and needle lokes. As far as our breast cancer diagnoses, we diagnose about 550 breast cancers per year. And we are part of a larger imaging organization, so we not only do breast imaging, but we do all types of imaging, including X-ray and CT and DEXA. But we're certainly known for our breast imaging and our expertise in that area. So when I was hired back in January of 2009, that's when we sort of started what we call our RAP program, or our Risk Assessment and Prevention Program. So I was the first genetic counselor that was hired, and then Allie, our second genetic counselor, joined us in April of 2013, and then we just very exciting recently hired a third genetic counselor named Jessamine, who we're very, very happy to have. So it's really, really incredible to see our program grow like it is, and I'm going to show you some data that kind of speaks to the incredible growth that we've had. When I was hired in January of 2009, my thought was, yeah, this is great to have a genetic counselor here and to offer counseling as part of a breast center. But I felt like we had such a bigger opportunity because we had all of these women coming through our center for breast imaging, and we were collecting information about their family history, but we weren't doing anything about it in most cases. And so my goal was not just to sit in my office and see patients for genetic counseling, but my goal was, how do we look at this system and look at it as a way to identify patients who might be high risk and empower them and their physicians to act on that, because there's so much data out there showing that high-risk women don't know they're high risk. Women who are BRCA, 1 or 2 genetic testing candidates don't know that they are. It's never been offered to them. And so that really was sort of my goal in creating this program, was to sort of look at this from a systematic approach. And so as a result, we developed this process that we started in November of 2009, where we systematically asked 2 questions about every patient who came through for a breast imaging exam. So we looked at their lifetime risk of breast cancer, and like Allie mentioned, we kind of had to pick one model. So we did pick the Tyrer-Cuzick model, and that's something that's built into our mammography software. And the goal of that is to identify breast MRI screening candidates. And then we asked that second question of, is this patient a genetic testing and counseling candidate? And so the answers to those questions, and I'll come back to this later, but the answers to those questions aren't always the same. We might have somebody who's high risk on the Tyrer-Cuzick model, but not a true genetic counseling and testing candidate, and vice versa, or somebody may be a yes to both of those questions. But we essentially built into our system so that we were asking that question of every patient who came through for a breast imaging exam. And then in our first stage, we were just assessing it and then communicating the recommendations to the referring physicians via the report from the imaging exam. So that was where the communication went. And then we sort of relied on those physicians to reach out to their patients to say, hey, I got your mammogram report, it's normal, but you have a recommendation for genetic counseling, let's talk about that. And then once we'd done that for about a year, we added a very carefully worded letter that went to patients who were flagged for one or both of these reasons. And so essentially we weren't just communicating this to the physicians by a report, but we were also letting the patients know, hey, you have some risk factors and you may want to schedule a visit with your doctor to talk about some additional things like genetic counseling or supplemental screening in addition to a mammogram. So we weren't cutting the physicians out of the loop, but really just sort of facilitating that communication between the patient and their physician about this specific issue. So this, in essence, is our diagram of how we do our personalized breast cancer screening recommendations. And again, this goes for every patient who comes to us for a breast imaging exam. So again, we're asking that first question about breast cancer risk and putting them in categories of high, intermediate, or average. And that's reported on every one of our reports. Our radiologist will put a category of what that patient's risk is. If the patient is high risk, we do automatically recommend that they consider annual breast MRI screening. And then, of course, we want everybody continuing annual screening mammograms. Now, you can see that we have some other recommendations that we can consider, especially for people who have dense breasts, which, obviously is a topic that's in the news a lot lately. So we will sometimes consider annual breast screening ultrasound in women with dense breasts if they're intermediate risk or even if they're average risk. But it's not a standard. It's kind of up to the radiologist to consider, and we don't send any patient letters about those recommendations. But the breast MRI screening is highlighted in yellow because that's something that if the woman is high risk, they automatically get a recommendation to consider that, and then they get a letter. And then we ask the second question about whether their personal or family history is suggestive of a hereditary syndrome. And we essentially use a really complicated algorithm that's built into our mammography software that's based on the NCCN guidelines, basically. And so if the answer to that question is yes, then we're also going to make a recommendation in that report for genetic counseling and testing. And then again, that patient will get a letter. So again, I really want to drive home this point that these are two separate clinical issues, and I will kind of maybe give you some scenarios of why these are two separate issues. So if we have a woman whose mother was diagnosed with breast cancer at age 70 and her paternal aunt was diagnosed with breast cancer at age 65, if she didn't have a child until she was 35, we run her through Tyrer-Cuzick, and she's probably going to come up as over 20% lifetime risk. So she's somebody where she is a candidate to consider breast MRI screening. But when you look at her family history, she has two relatives with breast cancer, but they're postmenopausal, later age, and they're on two separate sides of the family. So could she benefit from a visit with a genetic counselor? Certainly, and if she's concerned, she should have one. But according to the NCCN guidelines, she's not somebody that we would proactively recommend seeing a genetic counselor, most likely. So she's somebody that would fall in that the blue circle. Versus the patient that I presented previously, if you remember. She wasn't high risk on any of the models, but she had a family history that made her suspicious for BRCA. So she was in that green circle. And then, of course, we'll have the people who are in both. The woman whose mom had breast cancer at age 40 and her maternal aunt had breast cancer at age 45. That woman would not only be high risk on the models, but also a candidate for genetic counseling and testing. So again, these are really two very separate questions. And so often, I talk with physicians who say to me, oh, I'm looking for candidates for genetic counseling because I'm running the Gale model, and if the Gale model is high risk, I send them for genetic counseling. They're missing a lot of patients by running that Gale model. The Gale model is not designed to identify people who could benefit from genetic counseling and testing. So just to give you an idea, we did a data set of about 75,000 breast imaging patients over about a year's time, and we flag about 7% of them for something. So about 3% are flagged because they have a high lifetime risk and are MRI candidates, and about 3% are flagged because they are genetic counseling candidates, and about 1% are flagged for both reasons. We do have one general letter that we send to all patients who are flagged for any reason. And again, it's a very gentle language, and the call to action is for them to call their doctor and schedule a visit to go over, to talk specifically about their risk and what recommendations would be appropriate for them. You can see over time that we've really been able to grow our breast MRI volumes and also our screening breast ultrasound volumes. So, not only is this due to mailing these letters to patients and making the recommendations and the reports to the physicians, but it's also due to patients meeting with genetic counselors at our center and learning what their options are for screening. So you can see we really, really grew the volumes of both of these supplemental exams. We had a huge peak in MRI at the end of 2011, and then that's gone down a little bit since then. We're interested in looking at why that is. We feel like it may be due to some changes in insurance. A lot of people are going to those more high deductible plans, and I think that is maybe limiting the number of people who are wanting to proceed with an MRI because that's such a big out-of-pocket expense if it is a high deductible plan. But again, we kind of want to look at this data in more detail. But you can see, even if you look at the overall growth from Q1 of 2010 to Q4 of 2014, I think that's obviously a projected volume. But we've certainly, those are months, never mind, sorry. April of 2014, we've certainly grown tremendously, which obviously our CFO and president are very happy about. And then if you look at our consultations, so these are the consultations where the genetic counselor is actually sitting down with a patient and meeting with them and doing a detailed risk assessment, offering genetic testing if it's appropriate. You can see how dramatically our volumes have grown since 2009, and you can see our projected volume for 2014 in that little sort of lighter green area. The other thing that's really cool is that if you look at the blue bars, those are the percent of new patients that we are bringing into Invision Sally Jobe. So these are patients who were never seen at Invision Sally Jobe before, but they came here to see us for genetic counseling. And so a lot of these patients then end up sticking around and being our patients for year after year, which is very cool. Just so you're aware, we are seeing a lot of unaffected patients, so patients without breast cancer. That's about 3/4 of our visits, and then about 1/4 of our visits are affected patients, most often with breast cancer, but some of them may have other cancers as well. Our genetic test outcomes, we get about a 5% rate of patients who are positive, and people may feel like that's very low, but honestly that is about what we would expect. Again, we are testing a lot of unaffected patients. If you're looking at how many positives you'll get in an affected patient population, so if you're in like an oncology office testing women who have breast cancer, that positive rate is going to be closer to 10%. But we see about 5% positive. We see, again, the uncertain variants, the undecideds, and now we're tracking more than just BRCA1 and 2 outcomes, obviously, because we are doing these panel tests that have a lot of other genes involved. But this just gives you sort of a picture for the fact that you're not going to get half of your patients that are going to be positive for this. This is something that's still very rare, but when we identify it, it can be really, really important because it can drastically change what we recommend for these patients. This also just is a interesting sort of diagram that shows of the patients that we see for genetic counseling, where are their risks falling? And again, I chose just to include the IBIS or the Tyrer-Cuzick model risks. And these are, again, patients who don't have a breast cancer diagnosis and they have no specific gene mutation. But you can see that having a genetic counselor on site can help to identify a lot of high-risk women. And by the genetic counselor actually having that interaction with the women and really talking to them about their risk and what they should, what the standard recommendations are, we're capturing a lot of high-risk patients that we can then potentially keep in our system for additional exams. And, not just from a revenue perspective, but improve the clinical outcomes for these women. Identify cancers on an MRI that would have been missed by a mammogram. Start mammograms early in women that didn't know that they had to start their mammograms early. So these are all really important points to take home. Other interesting things, so like I mentioned, we're bringing a lot of new patients into the breast center. We're bringing them in specifically for genetic counseling, but about half of them actually stay in our system for other exams. And what's interesting is if you look at the average revenue per exam for the patients that we bring in the door, it's about 40% higher than it is for other Invision Sally Jobe patients. And obviously that's because these women are higher risk and they're doing more high-tech exams. But it is a very interesting thing to present, to a CFO or a CEO to say, hey, this is really beneficial for us to offer this. And obviously, this revenue increases year after year. So if we capture a woman in 2010 and we say, hey, you're a candidate to do mammograms and MRIs, she not only does the MRI that year, but she does the MRI year after year. And so that's something you can kind of see an exponential growth there. The other interesting thing is we started, and this is very basic data, but we started looking at the MRI compliance. So are the patients who see a genetic counselor and actually have that full session about their risk and what the recommendations are they better at complying with the MRI recommendations versus the patients who just get that letter in the mail, or perhaps their referring physician talks to them about the MRI? And our initial data shows that the genetic counseling patients are more compliant. We have about 60% of them that comply with the breast MRI recommendation in that first year versus about 40% who receive the recommendation in another way. Now, I think that we have a lot of opportunity to improve those numbers. Those numbers, to me, are a little disappointing, but we have some ideas of maybe, kind of creating like a nurse navigator position for these high-risk patients to try to increase the compliance with these recommended measures. But again, it just still is a good starting point to say that, hey, the intervention of the genetic counselor is actually increasing the compliance. And then, I think this pending breast density legislation is probably going to increase the need for risk assessments in genetic counseling, because you have to realize that you can't just recommend a screening breast ultrasound based on breast density because you don't know what the other risk factors are there. And it may be a patient whose risk is high enough that they need an MRI. It may be a patient who has density but also some family history that necessitates considering genetic counseling. And so I think in our center, we're leaning towards the idea that if we do have breast density legislation, the call to action isn't going to be just, hey, you have dense breasts, do an MRI or screening breast ultrasound. It's going to be, hey, you have dense breasts, which is a risk factor, and you should have that evaluated in the context of other risk factors. And so we're really kind of considering making that the call to action is dense breasts means you need a further risk assessment. And so I think that the number of genetic counselors that we're going to need is actually going to grow if that density legislation comes to fruition. So to summarize some key points, breast cancer risk assessment and genetic testing is becoming increasingly complex. With the various labs that are out there, with the different tests that can be run, with the panel of genes that we can do. It's not just BRCA 1 and 2 testing through Myriad anymore. There's a lot of other things to consider. I think the other important point is that the systematic processes are really key to identifying patients who can benefit. And in those processes have to be tailored for different populations of patients. So again, you kind of want to look at the patients with breast cancer or who have a history of breast cancer, and then the patients who haven't had any breast cancer. And you really want to come up with different sort of processes for those patients. You should be identifying about 15 to 20% of your newly diagnosed breast cancer patients for genetic counseling and testing, and about 6 to 10% of unaffected patients presenting for breast imaging, and that's supported by various publications that are in the literature. And then again, I want to drive home that for unaffected patients, you have to evaluate both the need for genetic counseling and the lifetime risk by a risk assessment model or more than one model. You can't just ask one question or the other. So that's something that's really important. And again, you know, really that if that patient's a candidate for genetic counseling, that's what needs to be pursued first, because the outcome of that genetic counseling may tell us that we don't use risk models at all. You know, if that patient does have a specific gene mutation, then there's no need to use those risk assessment models in them. And last, but certainly not least, I would just encourage all breast centers to think about hiring a genetic counselor or 2 or 3. I think partnering with them is great. If you have a really referral relationship with somebody in the area, that's wonderful. But I do think that there's something to be said about having somebody at your center to bring those patients into your center, see those patients at your center, and really play a role in setting up those system-wide processes at your center. And so, again, you sometimes can do that with a partnership, but I do feel like as time goes on, I think breast centers are going to be the next big area where genetic counselors are really going to become necessary. So I would certainly encourage you to think about hiring at least one if you don't have one already. So we would like to acknowledge the staff at Invision Sally Jobe and our radiologists at Radiology Imaging Associates who we work so closely with, as well as Dr. Laura Barkey, who's our medical director. And the National Society of Genetic Counselors is a wonderful resource. They have a Find a Genetic Counselor tool where you can look for a cancer genetic counselor in your area. They also have other great information about who genetic counselors are and you know, the benefits of working with us. So I'd certainly encourage you to visit their website as well. So with that, I am going to wrap up and turn it over to Rachel, who's going to lead the question and answer period.
Thank you, Mary. Thank you, both of you. You did such a great job. This is really a fascinating topic, so I think that we are probably going to have a lot of questions to answer, as well as the ones that were sent ahead of time. So we'll go ahead and jump right in. Okay, the first question is, how can we promote genetic counseling in a breast imaging department without worrying the patients?
Yeah, so I'll answer that one. And again, you know, it comes down to what I mentioned kind of with our letter. I think you have to carefully word what you're saying, because this is a sensitive topic. But I also think that you have to stretch a little bit. And the stretch for us was sending those letters directly to the patients. That was a little scary. But we worked so hard on that letter and the way it was worded. And I think, again, it's just, you know, balancing, you know, you don't want to alarm people, but you also want to let people know that these things are out there and that genetic counseling is an option. I think we always say, too, you know, you have to realize that genetic counseling doesn't mean you're going to come in our office and we're going to draw your blood for a genetic test and send you home. We are going to talk with you about the options, and most patients leave our office feeling so much better than they did when they came in. Even if they haven't had a genetic test done yet, even if they don't know what that result is, it just really helps them to kind of put things in perspective. And so I think it's all about balancing being informative with patients and letting them know their options, but also doing it in a very careful manner so that we're not unnecessarily scaring them. And again, really encouraging them that genetic counseling does not mean genetic testing. It just means that somebody's going to talk with you about the options that are available for you.
Okay, great. Thank you. The second question we received is increased risks associated with density. Also, on the Tyrer-Cuzick model, what category does a fibroadenoma fall under? No atypia.
So I'm not quite sure exactly what the question is with increased density, but as I said earlier, these models really don't take into account density at this point in time. None of the accepted models do. So as I discussed and Mary pointed out, you have to figure out how you're going to deal with those patients at your center. So for us, again, anyone over 20% risk, we do recommend doing breast MRIs, but we took into account breast density at the other levels of our screening as well. So for people who are intermediate risk and have dense breasts, or even who are average risk and have dense breasts, then recommending additional screening. But unfortunately, none of the accepted models currently do take that into account. For the Tyrer-Cuzick model and the fibroadenoma with no atypia, it's not taken into account at all with the Tyrer-Cuzick model. It doesn't take into account those benign biopsies, so we wouldn't input that information into that model. And
okay, thank you. Yeah. Okay, the next question. Some imaging centers use tools like Gale to estimate risk. Do patients who have this risk assessment need genetic counseling?
So this is Mary. I mean, I think I responded to that before. Not all patients who are high risk on the Gale model need genetic counseling. Can they consider it? Certainly, but they don't all need it. And again, the Gale model is going to miss a lot of patients who need genetic counseling because it only looks at first-degree relatives with breast cancer. It doesn't see paternal side of the family at all. It doesn't see aunts. It doesn't see cousins. It doesn't see grandparents. And again, that's why that model, it's very easy to use, but it has a lot of limitations, and that's why the American Cancer Society doesn't endorse it for identifying MRI candidates. So can you use Gale? I mean, you can. I just think you have to be very careful of what those limitations are. And again, if you're looking to identify patients who are candidates for genetic counseling, you really have to have some way to either identify people who meet those NCCN guidelines or just have some general red flags that you're going to pick up on for patients who might have a hereditary cancer syndrome.
Okay. The next question, what is the percentage of BRCA-positive patients that opt for prophylactic mastectomy nationwide?
So I re-looked up this number recently, and for some reason 30% was sticking in my mind for unaffected patients, but I couldn't find a good study that really parsed out the difference between affected patients who have had breast cancer and unaffected. They kind of were lumped together, and in those studies it was found to be about 35 to up to 45% of those individuals will choose to have a risk-reducing bilateral mastectomy or mastectomy at the time of their diagnosis. And about 74% of those individuals will have a risk-reducing oophorectomy.
Okay. Next question. Patients are often anxious to move forward with their breast cancer surgery rather than wait for a genetics consult and possible genetic testing to assist in their decision-making. Given the fact that only 5 to 10% of breast cancer patients have the BRCA1 and 2 gene mutation, when is it appropriate to test immediately, and when is it appropriate to wait and refer to it after surgery?
You know, I think in our center, we offer the genetic counseling immediately. The surgeons that we work with like that. They really enjoy the fact that, because typically at our center, the patient will get to the surgeon within about a week of their diagnosis. They usually get their diagnosis, and then in the meantime, they have an MRI, and then they get to the surgeon most often. And our surgeons love the fact that we've already talked with the patients about this, and the patient has either made a decision to move forward with the testing, and the testing's already a week in process, or the patient has decided, no, I'm going to wait to talk to my surgeon to see what they think. So honestly, I feel that it's appropriate to have the conversation with all the or at least offer the conversation to all patients right at the outset. Some of them aren't ready for it, and that's fine. We're not twisting their arm, but at least we're making that offer at that point. We do see some that decline the genetic counseling session initially, but then they get to their surgeon, and their surgeon says, hey, I really want to know this information in order to make this decision. Other times patients get to the surgeon and they say, regardless of what these genetic test results showed, I think I would recommend the same surgery. So every situation is different. And so I think we've just made the decision that we want to offer it initially right away. And, but some patients don't want to wait. And some patients do just go ahead and proceed with a lumpectomy, knowing that the genetic test results are coming. But we do find that that's a conversation that those patients can really have with their surgeon. And if we've already jumped on the genetic testing and gotten that started, it's very useful for the surgeons that we work with.
Okay, this question I think is really interesting. It is, how do you feel about providing genetic counseling services via Skype to outside qualified service providers?
So actually in our
Allie, do you want to take that?
Yeah, sorry. Actually in our center we have the ability to do telemedicine. So we work with centers that are outside of the state, or at least one center and another one that's further away from where we are, and do telemedicine services. So there are limitations to being able to do that, for example, like measuring head size for Cowden syndrome or something like that. But there are services that if you don't have access to a genetic counselor in the area, then that can be very worthwhile to figure out if they can have some kind of partnership with a genetic counselor via that way. because it is really important for these patients, even if they are located somewhere that's more rural and they have access to telemedicine and can't access a genetic counselor in person, that these people are being offered different services and different kinds of different opportunities that we wouldn't have had before to undergo genetic counseling. So I think that's what that question was referring to. But there are other services that do offer that type of thing that are more national.
Yep, and there's a company called Informed DNA that actually offers nationwide cancer genetic counseling by, well, actually not just cancer genetic counseling, but nationwide genetic counseling by telephone. So certainly, I mean, those, I think it's ideal to see a patient in person, but it's not always possible. So I think telehealth and telephone counseling are certainly options.
Okay, thank you. So a couple of people have sent in requests for the slides to be sent to them, and also questions about watching the recorded version of this webinar after the fact. The recording will be up on our website, priorityconsult.com, sometime hopefully in the next 24 hours. Sometimes it might go a little bit over or be a little bit sooner than that. And we do have a PDF of the slides. We can't send the actual PowerPoint, but we have a PDF that we can share. And so I'll probably go ahead and just send that out to everyone who attended the webinar today, right after we get off the phone or off the webinar. So everyone will have that. And then I do have a couple extra questions on top of that. So one of them is, could you share a copy of the questionnaire you are using? We are working on a pilot project in our institution to implement the screening tool. Ours focuses mainly on Gale model because we do not want it to be too complex.
We don't, honestly, we just use we have an intake form that we've created through our mammography software. My email is on this last slide, so I would just encourage that person to email me, and maybe we can, I'd be happy to share that with you, what our intake form looks like.
Okay. Let me just go through these. Okay. Somebody said that they were late joining and they wanted to know if you had already discussed your staffing. They say, I know you have 3 genetic counselors. What about administrative staff? How many patients do the genetic counselors see per day?
Yeah, so we do have administrative staff. We have an administrative assistant that supports all the genetic counselors. We also have 2 nurses who help us a lot with phone calls to patients. And then myself, I'm actually a manager, so I do see some patients, but a lot of my job description is more management. And so then we have Allie and Jessamine, who are both full-time. Allie, I would say on average you're seeing 4 to 5 patients a day. Is that about right?
Yep. Mm-hmm.
So hopefully that answers that question, I think.
Yeah. Okay. Well, it looks like we don't have any additional questions, so I think that's it for us for today. I thank you again so much, Mary and Allie. I think this was a great topic and a great presentation. And everyone, the recording will be on our website in about 24 hours, priorityconsult.com, and I will be sending out a PDF of this presentation in just a little while. So look for that. All right. Thank you, guys.
Bye.
All right. Bye-bye.